Good morning and good afternoon, folks. I'm Bianca Frogner. I'm a professor at University of Washington in the Department of Family Medicine, and I direct the Center for Health Workforce Studies. But more importantly, I'm part of the leadership committee for the Award Network. And today is our first webinar of 2024. And we're really excited to have Dr. Nathaniel Chin, or Nate Chin, join us today to talk about Alzheimer's disease novel therapies and what that means for clinics and the clinical workforce. Before I turn it over to him to speak, I just want to go through some additional house cleaning as usual. So next month, we have another speaker already lined up. Dr. Van Park from UCSF will be speaking about meaningful engagement of Asian American, Native Hawaiian, and Pacific Islander communities in Alzheimer's disease and related dementias research. So please go ahead and register for that. And as always, we always welcome ideas for future webinars. So you can scan that QR code there on the bottom right-hand side and share with us your ideas. You can also find previous webinars recorded, just like this one is today, online on our website there. I want to thank our webinar committee members, including Emily Franzosa, Madeline Sterling, Huiwen Xu, and Jarman Ye for their excellent contributions to this webinar committee. We could not be doing this work without all of their efforts to coordinate these sessions today that you see here each month. So some exciting things happening in the award network that I just wanted to alert people to in case you weren't aware already and are not already signed up on our newsletters to see some of these announcements. There's a research fellowship that has been open now for a few weeks, and applications are due February 28th. And this can cover some research costs that you may be incurring or expecting to come up to $5,000 in costs. So please check out our website to learn more. We're also super excited about a summer institute coming up this July in San Francisco. The website is the place to learn more about it. It's where you'll find an application. But the hope is that over this multi-day meeting that folks will have a chance to really understand what it means to conduct research in this space of Alzheimer's and think about the role of the workforce to care for patients with Alzheimer's and other dementias. And so this is really targeted towards people who are in their early stage of their career. So that can include doctoral candidates, postdocs, assistant professors. So please spread the word for those who you think might be interested or apply yourself. Also, there's an exciting new resource that has been developed and led by Lei Chen, one of our postdoctoral fellows. And so you can find this on our website. I try to identify where you can find it. This is under the resources tab of the Award Network, and it's a direct care workforce compendium where you can, the first product that's coming up is some information about state Medicaid waiver programs. But over time, we're going to populate this with even more information, and hopefully this will be helpful for you as you think about research ideas that you might do in the future. And I do want to just point out who's on the leadership committee of the Award Network, in case you're not familiar with some of the faces. Thank you to the whole team here for coordinating all these wonderful activities for the Award Network. And thank you to the National Institute on Aging, who is the sponsor for this today's event, as well as the network in its entirety. So with that, I'm going to just stop sharing, and I'm going to go ahead and introduce our wonderful speaker today. So I'll ask him to please turn on his camera so you can see him. So Dr. Nathaniel Chin is an associate professor in the Department of Medicine, the Division of Geriatrics, and he's a medical director of the Wisconsin Alzheimer's Disease Research Center, or ADRC, and the Wisconsin Registry for Alzheimer's Prevention Study, or WRAP. And Dr. Chin is a dedicated medical professional with strong academic foundation and a passion for advancing Alzheimer's disease research and care. He holds an MD from the University of Wisconsin School of Medicine and Public Health. And after his internal medicine residency at University of California, San Diego, UCSD, Dr. Chin pursued fellowships in both geriatrics and dementia at the University of Wisconsin School of Medicine and Public Health. Currently, Dr. Chin plays a vital role as a medical director and clinical core co-leader for the Wisconsin's Alzheimer's Disease Research Center. as well as I mentioned, the registry at Wisconsin for Alzheimer's Prevention, RAP. And his start to this field is really quite personal. His father had an Alzheimer's diagnosis early in his residency, and so that prompted him to become a geriatrician and a scientist focused on Alzheimer's disease and related dementias. And he's currently the associate director of the University of Wisconsin's Geriatric Memory Program and sees patients 2 days a week at the UW Health Memory Clinic. It's funny for me to say UW, I have to say, as the other UW in the country at University of Washington. So it's wonderful to have another UW person here. A different UW, but certainly a UW in the same family in that way. Dr. Chin's impact goes beyond the clinical practice, though. He hosts an informative podcast, which I highly recommend folks to check out, called Dementia Matters for the Wisconsin ADRC. And through this platform, he engages with Alzheimer's experts and discusses research breakthroughs and caregiver strategies in bi-weekly episodes to improve awareness and understanding of the field. So thank you so much for joining us today, Dr. Chin. I'm going to have you go ahead and start your slides, and then afterwards we'll have a bit of a conversation.
Okay, wonderful. Thank you for having me. It's an honor to be a part of this network today, and I'm actually very excited to attend next month. I'm aware of Dr. Park's work, and it's phenomenal, and so it's going to be a very exciting 2024 for the Award Network. Let me put on. Are people able to see this? Yes? Okay.
Yes.
All right. So I'm just gonna the initial questions that I wanted to address right off the bat before opening it up to you all to ask. You can see them here, and really the focus being in the beginning on what is really the difference between Alzheimer's disease and the clinical syndromes that we deal with. Oops. Of dementia MCI, and what really is MCI? How do we think of this process? How do monoclonal antibodies fit into an Alzheimer's disease treatment? What are the monoclonal antibodies? And then how are we going to try to fit them into the clinical practice, which I think we'll spend a good amount of our time talking about today. So I really wanted to start by just saying the definition of how we think about Alzheimer's disease has really evolved over the past 20 to 30 years. And it continues to evolve, and it actually continues to be debated to this day. And we're going to see more of that debate in 2024 when the new proposed guidelines come out. But really, one of the key factors in this is who you talk to. Whether you're talking to a clinician, it's going to depend on how they view Alzheimer's versus the next person. And so the clinician really focuses on the patient. They focus on the management, the care of patients. They manage symptoms, and they talk about plans. And so to a clinician, Alzheimer's disease is the cause of a person's experience. So that would be defined then as mild cognitive impairment and dementia. So we look to define the syndrome first of MCI or dementia, and then we're looking for clues that would point us in the direction to think it's Alzheimer's versus something else like vascular disease or Parkinson's disease or Lewy body disease. And up until the past few years, we really did rely on a clinical judgment without any sort of biological confirmation of that. But because of the help of this other perspective, the scientists are looking at pathology. They're looking at the underlying brain disease. They're looking at cells, and they're trying to understand this brain process and study interventions then with it. So to a scientist, Alzheimer's disease is pathology, it's biology, it's amyloid and tau, and then brain cells dying called neurodegeneration. And so they're looking at those changes to see when they develop, how they develop, what interacts with them. And they're trying to study that in the context of symptoms. And so you can see that there is a relationship between these two, yet they're still separated. And this tension has existed for some time, and it continues to exist. But with the advent of treatments that are targeting biology, it's really come to the head, which I do believe will be 2024. So when we think about Alzheimer's, we really do have to marry these two concepts of the experience of a human as well as the biology that occurs in the brain. And so if we think about Alzheimer's as these two abnormal proteins of amyloid and tau, then we can recognize they are a cause of progressive cognitive impairment, the experience of a person. But realistically, we know from our observational studies, RAP in particular, that there is a very long, prolonged pre-symptomatic stage of 10 to 30 years where a person has the changes of Alzheimer's, at least amyloid, but even amyloid and tau before they ever develop symptoms. And that took a long time to be able to identify and confirm because of we needed the tools to do that. And those tools really are PET scans, spinal fluid analysis, and more recently, blood-based biomarkers. Now, we know from our observational studies and from clinics that other diseases can masquerade, they can look like Alzheimer's disease, or they can co-occur. And so that makes the experience of a person, quote, not typical. And so there really isn't a textbook case anymore, particularly as people get older, because mixed disease is more common than we initially thought. So I wanted to show this slide because it's really the sequence of events that we still show in our observational studies and still matter. So the first little box you have here, if you can see this, is an amyloid PET scan. And so the red indicates the elevation, the yellow is elevation too. And so this person's brain has lots of amyloid in it. So there's this elevation of amyloid. And amyloid technically is normal. It's just that the buildup is not a normal thing. And at some point, which we have found to be between 7 and 12 years, a new protein inside of brain cells develop, which is tau tangles. And tau 2 is a normal protein, but it gets modified because of the presence of amyloid. And so here you have amyloid and tau, and that technically is the biological definition of Alzheimer's. At some point, your brain cells die, and when brain neurons die, they no longer release the neurotransmitters like dopamine and serotonin, and the memory one's called acetylcholine. And so people start to have symptoms with the death of the neurons. The reason I have this green bar is all of this can happen what we call preclinical. A person doesn't have to have any symptoms, but eventually there's enough brain cell death and deficiency in neurotransmitters that they then cross into the clinical world and they undergo some thinking tests. This happens to just be a picture of a mocha, but then they get diagnosed with mild cognitive impairment, which I'll explain in a second, and then they progress further. And they will progress further if it's truly Alzheimer's, and they'll get diagnosed with dementia. There's a picture of my father, and at this point he had moderate stage dementia, but you wouldn't know it from looking at him. This is a disease that it starts in the brain, it affects the whole body, but for a good percentage of the time, a person appears to be the same person, despite knowing that all of these changes are occurring in the brain. So dementia itself is a clinical syndrome. It's a collection of symptoms and signs. And we use the National Institute of Aging, Alzheimer's Association diagnostic criteria to determine it. And this is all based on from 2011. And so the key crux to this syndrome is that there has to be a cognitive symptom, some form of thinking complaint. It has to represent a decline from a person's baseline. So if someone is lifelong having issues with attention, we don't consider that to be abnormal unless it's more severe. On thinking tests, objective tests, there have to be at least 2 areas that are impaired or lower than expected for their age. And then it has to impact their day-to-day function. So as a geriatrician, I care a great deal about daily function. It's our quality of life. It's what makes us human. And in dementia, these thinking changes start to make it almost impossible to do some of those functions, like manage medications or finances, work, engage in your hobbies. And then we have to rule out other conditions like medical conditions, diabetes, vitamin deficiencies, and then psychiatric conditions. There are many different diseases that cause dementia. And you can see here Alzheimer's has a big chunk of it, but really Alzheimer's mixed with other diseases makes Alzheimer's the most common. And you will hear statistics 60 to 80%. It really just depends on who you're talking to and what study they're referring to. But Alzheimer's is clearly the most common. But after that, you have vascular disease and Lewy body disease as the next most common, followed by frontal temporal and Parkinson's. I will say Parkinson's, frontal temporal, Lewy body, these are all protein building up in the brain, different proteins, but proteins building up and in fact then killing brain cells. So mild cognitive impairment, on the other hand, it's not normal aging, but it's also not the same thing as dementia. The criteria for this are people with a thinking complaint, a decline from their baseline, and then they too have to have impairments on testing. They don't need 1 or 2 impairments, they can just have 1 because we think of this as earlier in the course of thinking change. But the biggest difference, I would say, is that they are functionally intact. Now, I say that intact because you could still have changes. You could rely on a GPS or use sticky notes. You could be less efficient than you used to be, and you can make mistakes. But as long as you're still able to be independent overall, we consider that to be functionally independent and therefore not having dementia. Now, in mild cognitive impairment, you still have the same neurodegenerative conditions, the same brain diseases of Alzheimer's, vascular, Lewy body, Parkinson's, and frontal temporal. But this category allows for many other things to cause MCI, and that would be underlying medical conditions. So that's where thyroid issues, B12 issues, sleep apnea come to play. Medications, which as a geriatrician I see a lot, and then psychiatric disease, so depression, anxiety, bipolar, even schizophrenia. So why does MCI matter when we talk about MAB therapy or monoclonal antibody therapy? It's really that the earlier we can identify change, the earlier for intervention, and arguably until you can stop disease in its tracks, then the earlier you address a person's overall change, then maybe you've changed the trajectory so that they're living longer with better abilities or more abilities. So this is a graph I commonly show, and on the horizontal axis, you have age. So you're getting older as you go left to right. And on the vertical axis, you have cognitive ability, cognitive function. So you're losing some of that ability as you go top down. And I want you to pay attention to the black line. This is normal aging. I'm tracing it with my mouse if you can see that. And you'll see that's not a straight line. So sadly, we all change as we get older. And actually, based on life course studies, you reach your peak mental ability at about the age of 25, maybe to 30, and then you start slowly changing. Most of the time, we don't notice any of this until about 60 to 65, when there's enough subtle change that people start reporting symptoms. And as long as there's not a disease of the brain or a medical condition, that's usually just age related. But for some people, there truly is a disease. And so that's going to be the red line here. And what's happening is you're accumulating amyloid and tau plaques, and you're developing brain cell death. And so there's a tipping point. And at that tipping point, a person deviates from this black line. They go to the red line. They get diagnosed with MCI. If they go in soon enough, they progress, they get diagnosed with dementia. So if we can identify MCI even earlier in this graph, then arguably if we give a right intervention and we change that trajectory, then a person may still decline, but they're going to decline slower, and it will delay the eventual diagnosis of dementia by years, and perhaps it delays being in a nursing home and they die of a heart attack or stroke instead. So that's sort of the thinking when we say getting to an earlier diagnosis is better from a treatment perspective. And that's certainly true when it comes to monoclonal antibody therapy. So when we think about drug targets of Alzheimer's disease, here's the plaques. Here's pathological slides of amyloid plaques and neurofibrillary tangles. And I'm not going to go over this schema below in detail, but I just want you to see that right here where my mouse is, this APP, we all carry this protein in the cell membranes of our brains. And there's a reason for that. It's been carried on in evolution. But for some reason that there's a trigger and we develop these abnormal amyloid monomers or single proteins, they build up and they eventually build into plaques. And so they have looked at many ways of trying to treat this. And so there are certain drugs that are trying to prevent even the creation of abnormal amyloid. They have not been successful in clinical trials. And then now we have more recent studies showing antibodies, so preformed antibodies that attach to different parts of this process, singular proteins, multiple, or the plaques themselves, to remove them. And so that's what I'll talk about in a few minutes. But there are other targets. There's research looking at tau, inflammation, keeping your synapses healthy. So there's a lot of different things that are happening. And in fact, in 2023, there are 36 different phase 3 clinical trials with many different targets looking to slow progression or ideally stop Alzheimer's in its tracks. So the three monoclonal antibody therapies in particular that many of you probably heard about in the news, they're listed here on the left, and on the right, this is a similar schema of developing amyloid plaques, so single proteins, multiple, they form these fibrils, and then eventually the plaque, and the plaque interferes with communication of other brain cells. But I want to start over here on the left. So aducanumab was the first FDA-approved monoclonal therapy. It happened in June of 2021 during the pandemic. It was through the accelerated approval. There's a lot of drama and a lot of conflict with this drug based on its approval and the science behind it. They had two phase 3 trials, which you need to have for FDA approval, and they were in conflict with each other. The one study called Emerge showed some positive results. The other study, Engage, did not show positive results. And so that was leading to some of the drama for its approval. It is a IgG1 antibody, preformed antibody, and it attaches to oligomers and fibrils. You can see this in the picture on the right. So it's removing some of this, the proteins leading to the plaques. Now, lecanemab, which is one more recently that was approved, and that was the traditional pathway for FDA approval. That was in July of last year. It's also an IgG1 antibody, but it attaches to a different part of the amyloid as it's forming the plaque. It's a little bit earlier in the disease course or in the plaque development. So yes, it's also doing fibrils, but it's also attaching to oligomers. And then lastly, at the bottom is donanemab. And this one is under evaluation. Many people thought it would have been approved at the end of last year, and it hasn't. It's still being studied by the FDA. It too is an IgG1 antibody, but it's targeting later in the plaque development, so the plaques themselves. And why does this matter, the target? Well, there are different side effects or different severity of side effects based on the target, and also just how effective they are at removing the amyloid protein itself. So donanemab is being shown to be the most effective at doing it. It also has the most side effects, followed by aducanumab and lecanemab. So how do they work? I'm really going to talk about the first two. These are three different proposed mechanisms of how monoclonal therapies are actually removing amyloid. One is this idea of direct action. These are preformed antibodies, the same antibodies your body would make if you had an infection. We're immunizing people, passive immunization, giving people these infusions. They're going into the brain, attaching to the amyloid plaque, breaking it down into those oligomers and monomers, and then being cleared through normal pathways. This certainly is occurring to some degree. I think it's donanemab now is proposed to be working more in the second proposal or mechanism, which is activation of microglia. These are the way we have white blood cells in our body that fight infection. These are sort of those types of cells in the brain. And so the antibodies kind of stimulate them, activate them, and then they phagocytize or eat up the plaques and then are cleared out. So these are two that many people think are really the drivers of how these monoclonal antibodies are working. And then lastly, there's this proposal of a diffusion mechanism by having more antibodies in the blood, where the amyloid is actually just diffusing because of a concentration gradient. So I did want to just touch on, well, what are the actual indications, contraindications, and how are these administered? And likely I'll have a couple of questions from you all about this too. I think the most important thing is who is this really meant for? And the indications are for people with mild cognitive impairment and mild stage dementia. So not moderate stage or severe stage dementia. And how you stage someone is going to be variable, and whether it's based on their functional ability or their thinking test scores, but the criteria technically are MCI and mild stage. And then you have to have amyloid. Otherwise, these medications are not going to be helpful. As far as what are the contraindications, which is a really important part to this, the pharmaceutical companies will say hypersensitivity reactions like anaphylaxis for those who have ever seen someone with a bee sting that develop the scary throat swelling and need to go to the hospital for epinephrine. If there are some people who could develop that type of reaction from the infusion, it doesn't happen very often. And so there were some appropriate use guidelines that were published by experts in the field, and they have a lot more to say, and many other exclusions to these medications. For instance, people who are on blood thinners would be excluded if you had a certain genetic risk. So ApoE44 are those with the highest risk of developing Alzheimer's. They too would be at high risk of developing bleeding in the brain. If you have advanced vascular disease in your brain, if you have other causes of your dementia, and so I mentioned to you mixed dementia is very common. Well, if you have Alzheimer's and Lewy body or Alzheimer's and Parkinson's, they technically would say that you should not be on this therapy. If you have autoimmune conditions and are on immunosuppressives like prednisone, they would exclude you from the medication. So there was a really important study that came out of the Mayo Clinic, Dr. Peterson's group, that said of all the people who may be eligible for therapy, after looking at the appropriate use, only about 10 to 20% would truly be indicated. So lastly, these are infusions. So you have to go to, think of it like chemotherapy. You have to go to an infusion center. It's about an hour long infusion, and you have to sit around for about 2 hours or more to make sure you don't have a reaction. And this happens for lecanemab every 2 weeks, and for the other two agents every 4 weeks. And the trial period was 18 months. So it's quite a commitment to do this. I did want to show you why the science is so excited about these agents. So on the left here, we're looking at the effectiveness of the drug in removing amyloid, and we're going to measure that based on amyloid PET scans. And so you can see placebo's in blue and the lecanemab is in, I think that's orange. And on this vertical axis, its Centiloid is a system of measuring how much amyloid is present in the amyloid PET scan. And so the downward projection or direction means removal. And so 50 to 60 centiloid removal is sort of the bottom here. And then you have multiple time points across the study. So you can see lecanemab, even at 3 months, successfully removed about 20 centiloids of amyloid. And then by the end of the study, it was over 50. And just for a frame of reference, having 20 to 24 centiloids is where you start developing or you're considered to have abnormal amyloid. And someone with Alzheimer's dementia will typically have around 100 centiloids of amyloid. So to reduce it by 50 is a pretty significant finding. On the right here, though, is the clinical outcome. What is it? What is the person and their family actually seeing, experiencing? And so the most common tool used to measure this is called the Clinical Dementia Rating Scale, CDR. It's been around for decades, and they use a subset of it called sum of boxes. And this really is an interview with the person with a disease and their family member or friend. And in this regard, you still have time on the horizontal axis, but now the vertical is a downward direction means decline. So you're declining in function and cognition. And you can see those on the lecanemab declined, but it was at a slower rate. And by the end of the study, they still had more abilities than someone who was on the placebo. And so those, and that for the lecanemab was about a 27% slowing. And those positive findings were enough to move the FDA to say, we approve of this drug being used in the real world population. And then eventually CMS said they would pay for it plus a copay. But there are things that we have to be very mindful of, and the major side effect or adverse event in the clinical trials was called ARIA, and that is an MRI finding, so amyloid-related imaging abnormality. Most people who have ARIA actually don't have symptoms, so it's identified on MRI, but there are plenty that do have symptoms, and those can be pretty severe, with 1% of people in the trials dying of bleeding in the brain. Again, small number, I think it was about 3 per study, but it did cause death. And so ARIA-E is swelling in the brain, that's this fluid, and then ARIA-H is the bleeding. And so people with ApoE4/4 have a higher risk of the bleeding, which is why the recommendation is not to infuse medications into those individuals. We're still trying to figure out why ARIA-H is occurring. There seems to be good evidence to show multiple mechanisms, inflammation, leaky blood vessels. But as you can see in the pictures here, A and B represent the effusion, the swelling, and then C and D represent the hemorrhage. As we'll talk about later, this is a very unique finding. About 8 to 10% of people with Alzheimer's will have this regardless, meaning they're not on therapy and they still have this. But this is not something that's commonly taught and seen in the real world of radiology and even neuroradiology. And so training is needed for those specialists to be able to identify these findings and convey that to specialists and primary care doctors. So this is a brand new process for the radiology world. So then when we think about memory care in general, and this is the world that I spend a good amount of time, there's really good publications about different models of care, but ultimately on the left-hand side here, they come down to a few key parts. One is continuous monitoring assessment. This is a progressive condition. We need to know, are they changing cognitively, but also functionally? And with functional change comes a safety assessment. So we need to do that at regular interviews or intervals. And then medication management. And that's where MAB therapy will certainly come into play. But medications to help with some of the functions, some of the cognition, or some of the related conditions or symptoms that come from it. At some point, we need to do capacity assessments because people are losing their insight. With a change in cognition and function comes changes in care, which also includes changes in how you view their other conditions, diabetes, hypertension, elective surgeries, cancer screening. Neuropsychiatric symptoms are very common and very difficult for both the person and their loved ones. And so being able to assess for and treat behavioral symptoms, advanced care planning is really an important thing for all medical care, but certainly in this condition, supporting and educating the family and care partners, and then just coordinating all of this care because this really is affecting the whole person, the whole identity of a human being. And so one specialty is not going to be enough. And that really speaks to, on the right, one of the best ways of providing memory care is a collaborative care model. And that's a multidisciplinary team. And I'm only going to speak to what we do in Wisconsin, but this is very similar to what happens in other memory programs that involve a team. You usually have a physician, a neuropsychologist who does the cognitive assessment, mood assessment, sleep, a social worker, a nurse, a medical assistant, and that's just to get to the diagnosis, the syndrome diagnosis and the cause of that syndrome. And then there's chronic care management. And this can often be done by primary care, but certainly there are programs like ours that co-manage. And for us, it's an advanced practice provider, a nurse practitioner, a physician assistant, but you're still having a social worker because of the resources needed, as well as the psychological changes that come, nurses, medical assistants, and sometimes there's a physician to help supervise the nurse practitioners or sees very difficult cases. And then there's many referrals that can happen. And so as a geriatrician, it's in my nature and my training to believe in the team and to utilize the expertise of others. And so we make lots of referrals to speech therapy, physical therapy, occupational therapy, psychiatry, psychology, sleep medicine, because we know that there's going to be many needs of the person with the disease as well as the person caring for that person. So to end, I wanted to show you sort of where do MABs fit into clinical care. And I think one of the questions that will come up is what keeps me up at night. And so this slide in particular keeps me up. In general, we have primary care that will they'll hear the initial memory complaint. They'll do some memory screening with a MoCA or a mini mental, and they'll do a brief evaluation. But ultimately, they make a referral to a specialist. In general, that's usually a neurologist depending on your geographic region. Sometimes it's a geriatrician or a geriatric psychiatrist where they do more evaluation, more history, more thorough testing in general, and then they do a diagnosis. After that, you go to memory care, and that's the chronic memory care model that I was just speaking about. So that's the traditional way that we've been doing it for years to decades. So where do MABs fit in? Well, I would argue that MABs not only fit in here, but even earlier. Many people are coming to their primary care provider because they've heard about MAB therapy and now they want to be evaluated. There are many people who think that, oh, even if they don't have impairment, maybe I should get on this MAB therapy for prevention. And there are, in fact, studies, and these are the very exciting ones in science, looking to prevent the development of symptoms by getting to people even earlier than MCI. But in the clinical world, we're not ready for that yet. And so they might come to the primary because of MABs. They certainly are going to talk about MAB therapy in that primary care visit, and that'll be one of the reasons we see this now as a referral to a specialist. For specialists, we're going to have to be ordering more tests. So there's biomarkers looking for amyloid because you have to have amyloid in order for the therapy to even be considered. But a part of that is also genetic testing because if you have ApoE44, you're going to be excluded, at least as of now, from this therapy. And then you're also looking for those other medications and chronic health conditions that would exclude you from MAB therapy. So these are new parts to a memory evaluation, and we're seeing this already in our memory program in Wisconsin. And each of these boxes is itself one or two more visits, and certainly hours on the phone that our social workers and nurses are doing. When it comes to the memory care itself, the chronic care, you're talking about MAB therapy, you're going to be doing more consenting and ordering to get people on the MAB therapy. And then lastly, over here is going to be all the things that come after memory care, working with the infusion center, working with the other departments, the emergency department, radiology, neurology, because certainly they're going to be involved for acute issues, working with insurance. In order to have the amyloid PET scan, you need to be on a registry so that CMS will pay for it. So working with your insurance to make sure everything is covered so that you're not having someone with a $5,000 cost. The monitoring is going to be quite intense. So there are MRIs that happen. There's an MRI that happens before the therapy, and there's at least 3 MRIs that happen during the therapy. And if you have any symptoms like a headache or confusion, an MRI will be needed to see if it's ARIA or not. I anticipate we'll be doing blood-based biomarkers to confirm removal of the amyloid and when to reinitiate, because no one is ready yet to talk about, is this like chemotherapy where you do multiple rounds of it in order to prevent or slow the disease even further? And then lastly, there are multiple visits just to talk about ARIA, just to talk about symptoms. And then what do you do once the 18 months is up? How does a person approach the rest of their care post being on a MAB therapy? And so the clinic world is completely changed, not only because of the blood-based biomarkers or biomarkers in general, but certainly because MAB therapy is here. And whether there are many providers that don't like it and don't believe in it, and they make references to the days of Aricept being first around, but whether you like it or not, it is here, it's out in the public, and people are asking about it. And many institutions will be using it. We have it at Wisconsin, and we anticipate many academic centers across the country will be using it as well. So I'm going to stop there. I'll stop sharing my screen.
Well, thank you so much, Dr. Chin. That was a wonderful presentation. I know I learned so much, and you said that so clearly, and there's a lot of information certainly to be learned. And I'm just going to bring up briefly, but we can certainly post it on our website too, that there are a couple resources just if people want to learn more that you provided us, including your recent publication on MABs, basically, it sounds like, and what it means for the hesitant geriatrician. And then there's the podcast that ADRC also has where I guess people can learn more about this. So I certainly want to share that with our community, make sure that they're aware of it, and we'll also post this on our website. But maybe to kick us off on questions, and I certainly encourage folks to use the Q&A function if you have any questions, but I do have some kind of pre-prepared ones that we can maybe talk a little bit about. And I'm going to actually start with the caregiver side, because many folks in our network are really interested in the caregiver's perspective as it relates to caring for patients with Alzheimer's disease. And given your own kind of personal experiences with it, I guess, what does all this mean for family caregivers, other informal caregivers, formal caregivers, whether it be, those who are home health aides or other direct care workers? What does it mean for folks in that arena in terms of what their role would be if MABs came to fruition and were more widely spread?
I mean, my initial reaction to this is that we need more care as a result of MAB therapy. Because these drugs do not stop disease, people continue to decline, but they slow it. It means you're going to be living longer with change, which means you're going to be living longer with needs for your instrumental activities of daily living, your basic activities of daily living. Possibly you're going to be living longer with having more behavioral symptoms or mood changes. And so for caregivers, initially, this feels, and it still could be a really good thing, especially if we address people in mild cognitive impairment and earlier, because you're really at your best at that point where you don't really need that much help and support. But for someone living with dementia, where you have more needs, you are prolonging that. You might be slowing and delaying other things, but a caregiver is going to be intimately involved in this process and needed for it. The appropriate use guidelines actually said if you don't have a person who can come with you to the infusion center, if you don't have someone who can help care for you at home, they wouldn't recommend this medication, which is a pretty strong statement. It's not mandatory, but I mean, they are thinking about this too, that our home health workers, we're going to need even more of them. And we already have a shortage of home health workers. But this idea that we are prolonging people living with need, it just means we need more care for those people.
So I can certainly see some research questions emerging there of, what does it mean? How many more people do we need if these kinds of treatments come online? Is that right? From your
I would say
opinion?
so. I mean, I have heard someone say to me when they talk about the cost of these medications, and it's about 26,500 for the 18 months. I believe that's for the 18 months of treatment. That does not include infusion centers, doctor's visits, and everything, or the workup for this. That they've also said it's about 10 to $15,000 a month to be in a nursing home. And if this shortens the stay of a person in a nursing home because they die earlier of something else, or not earlier, but if they die of something else, or it delays being institutionalized, that would technically justify the cost. But I would also counter by saying, well, we need more people in the nursing home because there's going to be people living longer in a nursing home.
I was
And
wondering
I
that
do think
too.
that speaks to why MCI and mild stage dementia were really the focuses of these therapies. They're not suggesting people who have moderate stage. These are moderate stages when you need help with bathing and dressing. They're not suggesting people with that level of impairment beyond these therapies.
Interesting. It really is with the goal of trying to keep people as independent as possible.
Right.
Okay. Yeah. So I was wondering about the implications that this means for skilled nursing facilities or just residential care facilities. And so it sounds like maybe within some of those settings too, as people might age with different conditions that put them in those settings, but they still might have this mild level of cognitive impairment that some of the patient mix may start to change and perhaps in some of these settings. Is that also a possibility? And what does that mean, I guess, for some of the preparations that these facilities should start thinking about?
I mean, so yes, I do that. I do think that's what it means that you might see people who are initially in a facility for a different reason. They're found to have earlier changes. They start this therapy. Those facilities would have to be aware of the potential complications. So again, this ARIA or side effects, being able to be connected to the hospital, to the ER, so that they know when to bring someone for an acute evaluation. We did not see behavioral change as a result of these medications. In fact, there was one study that was presented by Dr. Cummings, who wrote the appropriate use, that perhaps mood changes are less for a small subset. That was very preliminary, but so maybe there would be some benefit in that regard. But a lot of education is going to be needed, and given there's so much turnover in nursing homes, to be able to not only help people figure out the best way of caring for another person, but now the context of they're on this special therapy and their unique circumstances with this therapy, it's a lot to ask of nursing homes.
Sure. So, in that last slide, I appreciate that you mentioned all the different kinds of players that are involved in just in caring for patients, probably with dementia broadly, but MABs are seemingly going to bring people even more together. And you mentioned this concept of needing more education about these different conditions, and you specifically mentioned the radiologists needing, they need awareness of some additional things about what some of these, like ARIA showing up in these images, what to look for. I'm curious what some of the other education pieces are that you think some of the clinicians may need just to even get started on this path and prepare for this new world of MABs.
Well, I would say it actually starts before the MABs. We need more education for doctors and providers to understand MCI and dementia, because those are the two groups, right, that we're looking at. And then how to differentiate mild dementia from moderate and severe, because again, moderate and severe are not going to be eligible for this therapy. But then it goes to how do you determine that it's Alzheimer's disease versus another cause? We are still, as a healthcare culture, we still struggle with being able to accurately diagnose these things. But then on top of that, we need education on the biomarkers, whether it's a PET scan, spinal fluid, or the blood. And then we need education on the therapies themselves, the monitoring of these things. How does this impact other health conditions? And just as an example, these medications in essence increase risk for bleeding in the brain. So now if you're on this medication and you go to the hospital because you're having a heart attack, well, arguably you should not get a standard blood thinner for your heart attack, because that increases your risk of bleeding in your brain. And so how do we have these conversations, and how do ER docs and hospitalists and cardiologists handle that? all the circumstances are different. It's a complete culture shift. And so there has to be education on what to do in those circumstances. And so I mean, there's education at every step of the way, Bianca. It's just it completely changes how we've thought about thinking ability and dementia and Alzheimer's disease from a care
Right.
perspective.
Sure. And I'm curious, pharmacists certainly as a group that has gained more attention in terms of their high level of education that they've received and perhaps the somewhat underutilization of their skill set, especially out in the community, to help manage conditions. What's the role for pharmacists, do you think, for caring for patients in this context?
Well, I think they're absolutely critical. And in fact, at our institution, before we finally had monoclonal therapy, we went through a pharmacy organized committee to get a sense of who's the right person, not just because of MCI or dementia, but biochemically, and then how does this work as an infusion? What are the interactions with other medications we need to be thoughtful about? The side effects in particular, because not everything is about ARIA. There are other side effects that people can have. And so pharmacists really are the experts in medications, but medications, with the body. The pharmacodynamics, pharmacokinetics is what they look at. And so they're really, and it's not like we have a ton of pharmacists either. And so their time is going to be spent helping figure out which is the right person along with the clinician, and then what is the right way of administering this and monitoring this um, and really in the approval process of an institution, whether or not this is the right thing for a healthcare group.
Right. I see that Huiwen, one of our award network webinar committee members, has his hand raised, and so I want to invite him to unmute if possible. I don't know if you're saying something. We can't hear you. If so, if not, maybe you could type in your question also. All right. Well, we'll see if he can either patch in, or I don't think I have a way to unmute him, or maybe he can type in a question. I'm curious about, especially with the travel that might be involved with getting therapies. What does this mean for rural versus urban communities?
Well, we're really worried that this new therapy it's going to exacerbate disparities in care that already exist. And so in Wisconsin, we have a great amount of people who live in the rural parts, but that's true across the country. Getting to a center that is administering this medication and monitoring and has these PET scans and MRIs could be hours for someone, and that will likely be a barrier for people getting the right diagnosis, and then the therapy. And then in urban settings versus rural settings, even in big cities, being able to find access to the specialists that can diagnose these conditions and then monitor them. And so I think there's a lot of appropriate worry and concern that only a select group of people are going to be able to at least start this process of monoclonal therapy. I will say that as right now, you cannot use a blood test to confirm the presence of amyloid, and we're all hoping that that will change very soon. Certain blood tests can be quite accurate compared to the PET scan, and blood test is one way to break down a barrier, but you still need to have more healthcare providers. You still need to have more either memory clinics or specialists who can diagnose the condition. You need to have more infusion centers across, the state and the country so that people can receive that therapy. And then you need to be able to have this MRIs and the monitoring. One other thing that's breaking down the barrier is, I'm talking about infusion therapies, but these drugs and newer ones will likely in the future be given subcutaneously, like insulin. And so that will reduce a barrier of administration. So you don't have to be close to the infusion center. But there's still the issue of cost and the insurance coverage and just seeing the provider. And those barriers are very real. And so those will have to be addressed as more and more people are seeking treatment options.
Well, and you're teeing up Huiwen's question well, which is asking, and I did wonder too, is how much CMS or private health insurance actually covers MAB, or what kind of discussions might be had right now on it. I know with the earlier kind of drugs, and I'm still really struggling with pronouncing aducanumab.
Aducanumab.
Aducanumab, that there was a lot of debate about the high cost of that and what that meant for Medicare to cover, and just recognizing that a lot of people in that mild cognitive impairment stage, or even maybe before Medicare kicks in for many patients. And so I'm curious, kind of the discussions that are being had about CMS and private health insurance coverage around MABs, and what do you know about that conversation?
Well, I mean, these are ongoing conversations among all healthcare institutions and insurance companies, because not all insurance companies are covering it. Many are, and I would say once CMS said that they would cover, I want to say CMS said they would cover 80% of it, or they would cover all of it with a certain copay that would still amount to thousands of dollars per year. And so the drug itself, as I mentioned, was 26,000 plus. I mean, it was not, aducanumab was in the 50s. It was really exorbitant. And there was a part of the drama and the pushback. And 26,000 is still a lot. But I would say to the audience here, chemotherapy is really expensive. And I don't hear a lot of people challenging the cost of chemotherapy to the same degree that they challenge this one. And I just
Interesting.
pose that question because to question the cost of a geriatric medication and not the cost of a rheumatologic, asthma, or cancer medication could appear as ageist, that older
Mm,
people aren't worthy of a $26,000 medication
good
versus someone
point.
else. And so as a geriatrician, I'm always very careful to comment that cost is certainly important, but it should be important across all disciplines and not just geriatrics and Alzheimer's disease. And with this drug, it's not only the cost of the drug, it is the cost of the infusion, the medical care, the monitoring, the fancy imaging and blood tests to get onto the medical care. And so all of that, it is expensive. And the question comes up then appropriately, is that worth these slowing of decline and the benefit? And that's where it gets really, I would say, heated and emotional. And certain community organizations push very heavily to say, yes, it is worth it. There are certain economists that would say, well, I don't know from a financial perspective. I will say I'm a part of many conversations where it goes either way, but in the room with the patient, it's a much different feeling because on a one-on-one basis, if there's something that can prevent you from having dementia by 1 to 2 years, that's a hard thing to tell someone we're not willing to pay for that.
Yeah.
And that is not a conversation I like having in the clinic about costs. But it is a conversation that needs to happen because again, they're going to pay thousands of dollars out of pocket for this. And there are people who want to pay the whole amount right now because they really want this medication, but
Mm.
it's not perfect. It's far from perfect. And so I do think the cost needs to be included in all of these conversations, but I also just caution, why is it this conversation? Is it just because there's so many people, or is it because the source of the question is whether or not it's worth it in a 75-year-old to have something that would provide meaning to them, but and slow their decline? Because I just worry that some of the source of these questions are simply because historically we have not valued older people the way we have someone in the middle adult life.
I really appreciate kind of the framing of that. I think that's so helpful and important. And someone who comes with a health economics hat, I can certainly understand where those conversations are probably coming from. But it does certainly point to, I think, my first where I started is this question about caregivers and maybe all the other family members and the value of what it means to keep people healthy and well at an older stage, and what's the value there. And I don't think we have very good analyses maybe suggesting what value looks like for all the people involved in caring for patients with Alzheimer's, or people, family members with Alzheimer's. Yeah. Well, I know we're kind of getting close to the top of the hour here, and this has been a great conversation. And I'm just curious because you do mention some policy hurdles and things that might limit or maybe even help facilitate access to MABs in the future. I guess what excites you about the discussions that are being had, maybe especially in the policy sphere? So
Well,
a lot of exciting stuff happening in the science stuff side.
right. I guess what I think of MAB therapy as something that's stimulating a conversation, which I think is more important on how do we care for each other. And so, because we're still going to have care. So I think of MAB therapy as just a piece of that bigger memory care slide that I showed everyone. And so this idea of earlier screening, so from a policy perspective, earlier screening, earlier identification, I think that's wonderful and what we need to be focusing on. Being able to care for people in their own homes, so sort of social welfare is a really important piece to this. And map therapy is stimulating those conversations. So I'm very appreciative that this drug, while imperfect, is getting this idea of early identification, early conversations with your family and provider, advanced care planning, and creating a team of people, healthcare and informal, that will help take care of each other. And so as the geriatrician, I very much am working in that direction and thankful that MAB therapies have prompted it. And from a policy perspective, I hope it stimulates more policies that support the community in caring for people who have thinking changes.
That's great. So do you have any other last thoughts you want to leave us before we depart today?
Well, I guess the one thing I'll say is it's not just going to be about MAB therapies. The
Mhm.
exciting thing, and I didn't have time to show this slide, is that there are a lot of different targets for drug therapy, the tau, inflammation, oxidation, vascular remodeling, even the mitochondria, the cells that provide energy. Scientists are incredible, and they're looking at every possible aspect of trying to figure out how to keep the brain healthy, regardless of disease, and then also how to treat disease. And so we always hear about MABs and amyloid, and that is an incomplete picture. And I would say that the scientific field is trying to be broad, and they are really trying to do a lot of other things. It just doesn't get the media attention that many people see.
That's
And
interesting.
so, just to reassure you that the field is trying to get at every angle of
Mhm.
Alzheimer's and just all dementia.
Yeah, and it's a good reminder too for folks who are listening in either today or in the recorded version is that, there are many things to be paying attention to around treatments and prevention of Alzheimer's disease and to not just be swayed by what's happening in the media.
Right.
Yeah.
Right.
Well, thank you so much for your time today, Dr. Chin. It was wonderful to have this conversation and such a nice, clearly laid out kind of plan, understanding of what's happening today. So I appreciate your time.
Well, thank you for having me. I look forward to being an audience member next month.
Well, that sounds great. All right. Well, see you all next month then. Thank you so much. Have a wonderful day, everybody.